So, hi everyone. We are going to do our pediatric fact assessment sheet on skeletal dysplasia. My name's Akita Green.
I'm Sean Dowling.
Hi, I'm Sarah Houchin.
Hi, I'm Lauren Lever.
And hi, I'm Julia Seymour.
So we are going to begin. Oops, sorry.
So I'm going to be introducing our client. Her name is Anna. She's a 16-year-old girl with skeletal dysplasia. She does well in school, but she does struggle in PE class, and she does have a lot of friends and is active in her church choir. She works at her local movie theater and drives one of the family cars to work every day, which at times can be a struggle for her. She currently resides in Richmond, Virginia in a 4-bedroom house that she shares with her other siblings. And at home, she lives with her family, but her older brother is currently away in college. And other than that, she has 3 siblings that she enjoys spending time with.
So to give a little background about skeletal dysplasia, it is typically noted by a child's parent or a pediatrician during their first year of life. So what happens is the child's head grows out of proportion to his or her body and or limbs. It is diagnosed through clinical examinations, molecular testing, and radiographic imaging. And to determine the severity of the spinal problem, you look at the age of onset, the rate of progression, and if surgery is needed or required later on. Some forms of skeletal dysplasia can be diagnosed by an ultrasound before birth. So some etiology and statistics, it is a large non-uniform group of genetic disorders that affects the growth and development of the skeleton. It results as a mutation of an individual's genes. There are over 400 distinct skeletal dysplasias, which are divided into 42 different groups involving 364 different genes. It's a rare disorder affecting 1 out of 3,000 individuals. Individuals can also demonstrate abnormalities with their vision, hearing, pulmonary and renal or cardiac functioning.
All right, so now I'm going to talk a little bit about the signs and symptoms of skeletal dysplasia. Most often, these are able to seen with the naked eye, so you can see them physically within a child. Some of these symptoms do include shortening in the bones or the legs or arms. This would be characterized by short stature. An individual would look a little bit shorter, or maybe their arms are a little bit shorter, their legs are a little bit shorter. Also characterized by regular thickening or thinning of bones. A lot of times this occurs in the spine and can cause some spinal compression for these individuals. We also have bowed or fractured bones, absence of a limb, lower or upper extremity sometimes occurs, not as often, but it does occur sometimes in individuals with skeletal dysplasia. They often endure a lot of pain and fatigue, especially when engaging in movements. And then because of this, they do in fact have poor mobility and physical functioning in a lot of things, and this does inhibit a lot of their daily activities, unfortunately. You'll also see asymmetric bone growth, and as we said before, abnormalities in the size and shape of the arms, legs, full. So on to disease and medication management. There's several different ways to manage skeletal dysplasias. A lot of this is through orthopedics, neurosurgery, pulmonary services, enzyme therapy, bone marrow transplant, and then most commonly surgeries. There actually are not really any oral medications or pharmaceuticals that are taken currently to treat skeletal dysplasias. So most often or not, it's determined if the child will need surgery or not. And surgery often consists of joint replacements, leg lengthening or shortening if they have a shorter limb, reconstruction of different issues, and then they will also do soft tissue surgeries to prevent for contractures. But as of right now, the biggest thing is just making it an interdisciplinary services between a lot of different teams and a lot of different medical professionals to help that child kind of decide what their best case is. There's not one set way to deal with skeletal dysplasia.
So the implications for occupational performance, one of the areas in which a child or a person with skeletal dysplasia will suffer or will have difficulty is obtaining and holding objects. So for example, as seen in the picture, the lady needs to use a chair in order to reach the items in her fridge. And as you can see from her short stature and from the shortening of her arms, it's difficult, or it could be difficult for her not only to reach the fridge, but also to reach to the back of the fridge or to reach, say, the microwave on the counter. So the performance skills affected would be difficulty obtaining and holding objects, specifically in the reaching subcategory. Another thing would be reaching items that are up in shelves above, because a lot of times the people that have skeletal dysplasia don't have houses that are built for them because they can't afford it. So it's a regular house, and then it's difficult for them to do things like wash their dishes, reach the fridge, reach their shelves, reach their cabinets. Especially in the case of our patient, she's a child. She's a teenager, so she is not able to reach things in her house as easily as anybody else in her house would. So a big problem with this is that it restricts independency. So people with skeletal dysplasia are not able to be independent because, for example, they need someone to reach things for them. They need someone to bring things closer into their reach. So that's one of the big problems that people with skeletal dysplasia suffer from, is they're not able to be as independent as they'd like to be. It also can affect ADLs such as feeding, dressing, grooming, toilet hygiene, and bathing. Because of their short stature and their shortened limbs, it's difficult for them to do things like feed themselves or dress themselves, because you have to reach into the closet or reach down to pick up socks or shoes. So that can become very difficult. Another area of an implication of occupational performance that we found in the OTPF are the beliefs. So client factors, their beliefs may be affected. Physical differences, and short stature can lower the client's self-confidence. A lot of times people with skeletal dysplasia have lowered self-confidence because they feel as if they're always being looked at. They feel as if they're different. Specifically, children like to play with other children, and they notice when they're not growing at the same rate as other children, when they can't play the same way as other children because of their height. So they believe sometimes that they're only seen for their disability and not for any of their other qualities. It also makes it difficult for children to engage socially because they feel as if they're different, they stick out, so they don't want to put themselves out there and engage in social participation or in conversation with others. So their overall motivation to engage in occupations is decreased because of those self-confidence issues and the way that they're feeling. And those beliefs are something that an occupational therapist would work on with a person with skeletal dysplasia, because in order to change that mindset so that they would be able to participate and have friends and be more comfortable with who they are. The last area of implication of occupational performance that is affected, are their routines. So performance patterns may be negatively affected, their routines, because they are unable to perform ADLs. So in the case of our patient, her bathroom sink and her mirror are too tall because they are in her house for her siblings. And so that means that she requires a step stool, and it's important for her to use a step stool, but then her brothers and sisters move the step stool out of the way because they don't need it. So it becomes very difficult for her to complete her hygiene and grooming tasks without assistance. Sometimes it's hard for her to reach the toothbrush or reach the toothpaste. So that is how her routines are affected. Same thing with preparing herself food or breakfast before school and cooking. It's very difficult for her to reach the stove, reach the fridge. So those routines are impacted because she's not able to do it by herself.
So now we're going to talk about some of the occupations that are affected by skeletal dysplasia. So the first one we're going to talk about is functional mobility. So it is common for individuals with skeletal dysplasia to have deformities in their lower extremities, to have limited range of motion, and to have joint pain. So how can we as OTs help this? Well, we can help them by navigating assistive devices in different environments and also adapting their environment to fit their needs. We can also help them with functional range of motion, and we can also help them manage their joint pain. So the second occupation that we saw was affected was social participation. So individuals with skeletal dysplasia can have trouble with social participation, such as family participation and informal social relationships. So we can work closely with the family to make sure that they're engaging in activities that the client feels included in the family dynamic. And we can also help set them up with support groups and conventions where they can meet people who have similar life experiences. And the other occupation we chose was driving and community mobility because our client is 16, she's learning to drive a car. She may have difficulty reaching the pedals and the steering wheel of a car due to the shortening of both the upper and the lower extremities. So what we can do is we can help her find some assistive devices such as like pedal extensions and maybe something to help her reach the steering wheel easier. And then we can also educate her on how to use those assistive devices. So in one of the studies, they found that individuals also had a difficulty using public transportation. So we could also help with navigating public transportation, and if they have any assistive devices on how to navigate public transportation and other community services with those assistive devices. And then also, if we notice that there is an issue with public transportation, we can advocate for our client to help get those public transportation and community services up to the needs, like of if we see a lot of clients with skeletal dysplasia, if that is really an issue, we can advocate for that within our community.
And as we said earlier, interprofessional care is very important for treating skeletal dysplasia. We see a lot of physical therapy, ENTs, which are ear, nose, and throat specialists, neurologists, and neurosurgeons. So physical therapists will really help with strength and range of motion in joints and pain management. And ENTs will assist with hearing screenings, eating and swallowing, because as we did say that a condition is brittle and crowded teeth. Neurologists and neurosurgeons are really important for skeletal dysplasia because they assist with fusing spinal stenosis and stabilizing the cervical regions. They also treat hydrocephalus, and they remove the bones constricting the spinal cord and brainstem of their patients to help relieve some pain. And these are our references. And that concludes our pediatric fact sheet on skeletal dysplasia.